Welcome to Theatre B Old Art Building, University of Melbourne. Thank you very much for coming to ISDF 2018. First of all, I would like to begin with acknowledging the traditional owner of the land of which we meet today. I would also like to pay my respect to elders past and the futures. Before we begin, I would like to introduce our committee. My name is Lukman. I'm becoming the moderator for today's panels. And there's also Lucy as the event supervisor. Lucy, can you stand up? And then there's also Andrea as presentation manager. And then there's Putri and Weni doing the documentation. Weni and Putri holding the camera. And then there are also Hariyanto as the usher. She's outside, looking for the more participants to join in our panel. So before we begin, I have a little bit of housekeeping and a rule of presentation. The first one is please turn off your mobile phone and keep silence during the presentation. And the second one, each presenter will present 15 minutes presentations and 5 minutes question and answer. It should be 10 minutes because we're running late, so it's only 5 minutes for question and answer. And then I will be the timekeeper and remind you on 5, 3, and 1 minute. And then I will introduce each speaker while preparing or in between each presentation. And then this event will be documented, so anyone who didn't want to be documented, please inform our committee. And then the last one is if some of you want to have a Maghrib prayer, we have sajadah on the back, so maybe in between presentation, if you still have wudu, you can do the prayer at the back. So we shall start the presentation or the panel presentation. The first speaker will be Hadi Hariyanto. Please, Hadi, to be in the front. So, Hadi is a PhD student in the Faculty of IT in Monash University. And today he will present about the challenge in the implementation of Health Information System, learning from Bekasi District, Indonesia. Time is yours.
Thank you very much. Good evening, everyone. Anyone of you from medical or healthcare background? Okay, thank you, Mas Lukman. Okay, great. Imagine when we come to any medical center in Melbourne, you may see different type of interaction between people and technology. Sometimes we imagine how come Indonesia can implement such things the same as Melbourne. Today I will present part of my research about health information system implementation in Bekasi District. Why I choose Bekasi? Because it's among the first district that managed to implement health information system in all primary health center or puskesmas. I said, okay, I use puskesmas for Indonesian terminology. And until now, probably takes 2-3 years or 3 to 4 years that I can learn something from the struggle, the success story from there. Basically, I have two motivations personally. During the MDG, Millineum Development Goals Hadi, in 2012, I joined a project called Untitled, which is basically digitalization of maternal and postnatal care information system in Bandung district. At that time, I believe that why West Java, even though among top number 2 or 3 in terms of infrastructure and economical development, the number of mortality of maternality rate is the highest in Indonesia, and it's a surprise for me. That's why we joined the project and allowing midwife to play with iPad and mobile phone and blood pressure monitoring and mobile CTD, cardiography, so directly input to the system. Regardless we built the system participatory, user info from the beginning, but it didn't take up very well. Unfortunately, there are many prototypes coming from government, from research institution, failed in some way. That's why I came to this decision to do this research. After I joined the Monash University, I realized that according to WHO, the Health Information System in Indonesia exists but not functional, basically to monitor the Millineum Development Goals target. Regardless, Indonesia has implemented a standard reporting system since 1981, among the best. Many countries from Southeast ASEAN learned from Indonesia about this system. And we managed to implement the first electronic version of this standard in reporting in 2011, when our government launched SIGDA Generic, basically a information system for Puskesmas. But the take-up rate is quite slow. Only 20% of the district use the SIGDA Generic. In majority, the system still rely on paper-based. My research focused on the district, which is 35%. Why they choose another third-party system? It's use an electronic system, but not SIGDA Generic. Okay, this is the complexity you may see from the graph there. From macro perspective, Indonesia have two major challenges in terms of health information system implementation. First, fragmentation implementation due to the lack of coordination, integration among different stakeholders, including international donors. When HIV came, for example, or avian flu came, suddenly WHO chose Indonesia as part of surveillance system. And among the program, of course, there will be, for example, surveillance for avian flu under communicable disease control. Yes. The second complexity coming from the growing complexity of information system itself. Currently, what our government have is a primary health center information system, which is called SIGDA Generic. However, on top of you may know the outbreak recently appeared in the mass media from Jakarta, diphtheria, or from asthma about malnutrition. It is coming. When I asked PSC manager, what happened? Yeah, if the case already in the journalist, in the hand of journalists, mean there is some causality behind that. It's too late. So the question is, who is the most knowledgeable person in that situation? Of course, one of them is primary health center managers. Based on the interview, he said that every month they should deal with 50, 60 reports that should be submitted hierarchically through the district, province, until Ministry of Health, which took about 40% of staff workload. Imagine the staff should deal with the patient as well as to the recording, all kind of stuff. I believe without information system, electronic information system, of course they can manage to get the data, but there would be very difficulty to have data integrity, quality issue, and etc., as indicated by WHO report. Luckily, our government we have several progress. For example, the ITE law, which is give indication about the that electronic version can be evident of in the law or in the medical version. And the SIGDA generic is still growing right now, and our government vision and toward One Health data, which focus on the standard, how to simplify the data set. So in order to simplify those complexities, and also there is a talk about the interoperability among different health information systems. My focus it is not in the macro level, but I want to learn what's happening in the primary health center who managed to implement 3-4 years. Do they have such beautiful thing like what we have in Melbourne here, where we can find probably GP can talk with the patient while read the medical record and probably searching some medicine from internet for prescription. This is what I'm doing right now. I'm asking, for example, what factor do influence the district and healthcare practitioner adopted health information system. And I believe those factors, it is not stable. I mean, it is not really affected by organizational dynamic or people resistance. In that way, I will try to learn this factor, how they affected each other in terms of the stability of health information system. This is the method I use. There is a theory called actor network theory. Basically, the theory tries to bring more balance between technology and people. I mean, technology can influence us. For example, you hold a mobile phone everywhere. When the mobile phone makes something for you, usefulness, mean you being affected or you being addicted and rely on that technology. In this case, I use actor network theory to track the people and also the report, whether the report coming from the health information system or the paper-based. And those are the participants I got. And for the analysis, I used another framework called Human Organization Technology Fit in order to track the interaction among different factors. This is the software. The software rely on the cloud computing, where the medical data is stored not in the district, but in the cloud computing provider. You can imagine what the real problem behind putting the medical data in the cloud computing, probably data security, and etc. This is the adoption. Why Bekasi District choose e-Puskesmas? Based on the interview result, I realized that the decision for adopting the health information system is not only driven by internal factor. For example, here in Bekasi, they want to introduce internet to all the employees in the district. And secondly, they want to simplify the data, to deal with the fragmentation. But however, there is an external trigger from the previous project. In 2010, Bekasi tried to build their own health information system by failed in some way. And then in 2011, Ministry of Health invited Bekasi to join SIGDA generic trial. This is among the first. And unfortunately, after 1 year trial, Bekasi decided to quit that initiative because of the lack of maturity of the software and there is a supporting issue. At the end, they choose what is available at that time. Okay, because Bekasi already invested some money to implement Sigda generic in all PSC. They have a threat from corruption eradication commission. So with they have to be they have to justify all the capital expenditure issues. So by choosing more mature health information system. Why e-Puskesmas? Because at that time, Bekasi didn't want to add another investment, but rather choose what is existing one. And secondly, they don't want to invest a lot of money in the people to maintain the software. And third, they want, if it is failed, I mean, if the dealing with e-Puskesmas is also failed, they just cut the contract and move to another health information system. So this is the currently health information system already used by Bekasi, but regardless the use doesn't mean make a change of the current practice. There is mismatch here. For example, there is an attained goal, full paperless and automation didn't really happening because of the limited number of personal computer, and also there is organization issue. Leadership play important role. In the first 2 years, the leader is very fussy in technology. They maintain like a live laboratory that allow e-Puskesmas growing from one district to another district. It's like a benchmark center. But unfortunately, after 2015, there is change. I think based on regulation that the health information system section is merged into planning section and reducing the numbers of people involved. Since then, the support, the leadership is weakened and affecting the flexibility of the software itself. Okay, this is to end my presentation. The software should be fluid enough to anticipate new requirement, regulation, and system integration. And currently, system availability and reliability could be improved by fitting between infrastructure and IT support. And local policy and leadership play important role, which is missing in the last second years. And if Bekasi wants to improve it, I think it is not only about technology, but also organization issue.